Hello, and welcome to Blue Cross North Carolina's webinar on frequently miscoded risk adjustable condition coding. As we get started, just a few housekeeping rules and answers to frequently asked questions. We kindly ask that you disable any and all AI note taking tools. These are prohibited and will be manually removed once the session begins. Today's presentation will be available on Blue Cross North Carolina's Provider Risk Adjustment webpage for educational use. If you have questions, feel free to drop them in the Q&A box, or you can email us at bcbsncradj@bcbsnc.com. We will follow up with responses via email after the webinar. Presentation slides will also be provided with your CEU certificate. This presentation has been approved by the AAPC for one CEU. Please note you must attend at least 75% of the presentation in order to be awarded your certificate. Certificates will be emailed within 2 weeks of the presentation to the email address used during registration. If you have not received your CEU within 2 weeks, please contact us via the email at the address listed on the slide. This presentation is intended for both physician and office staff. The information contained in this presentation and the responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered on a case-by-case basis and should be supported by the medical necessity and the appropriate documentation reflected within the medical record. Before we begin, I'd like to introduce our risk adjustment provider engagement and education team. Our team is comprised of experienced nurses and coders from diverse healthcare backgrounds with over 30 years of combined experience in risk adjustment and clinical care and coding. They bring a wealth of knowledge and expertise to our program, ensuring we provide quality risk adjustment education and support. Our mission is to empower providers in risk adjustment coding and improve chronic condition management. Our presenters today are Missy Leggett and Dominique Brown, and I am your host, Jacqueline Duncan. Lastly, here is a brief overview of the key objectives we aim to cover in today's webinar. While our intention isn't to turn you into experts in frequently miscoded risk adjustable conditions, we do hope you leave today with a greater confidence and clearer path to success with encoding these types of visits. With that, I will hand it over to Missy Leggett to get us started. Good afternoon, Missy.
Good afternoon, Jackie. Thank you, and welcome everyone. We are going to begin today by reviewing the impact of provider documentation and inaccurate ICD-10 coding. Clear and accurate documentation impacts providers, patients, and payers alike. For providers, precise information ensures continuity of care between PCPs and specialists, while missed or miscoded conditions leave gaps in the patient's story. For patients, every active condition should have a treatment plan supported by the MEET criteria: monitor, evaluate, assess, and treat. Unclear or contradictory documentation can lead to under or over treatment. For payers, incomplete or conflicting diagnoses make it difficult to validate conditions with CMS, which affects reimbursement, resource allocation, and policy decisions. Ultimately, accurate documentation and coding empower providers and health plans to deliver appropriate care and maintain compliance integrity. Using unsupported codes increases the risk of RADV or OIG audits. From an audit perspective, especially in risk adjustment data validation or RADV reviews, documentation accuracy is critical. CMS auditors are looking for clear, consistent, and clinically supported evidence for every diagnosis that maps to an HCC. Diagnoses must be clearly supported in the medical record to avoid exclusion. When payers and providers work together to ensure documentation and coding accuracy, financial stewardship, and compliance integrity are supported. Some common RADV findings include unsupported diagnoses, documented diagnosis but not submitted on a claim, incomplete and or missing documentation, overuse of ambiguous codes, and unspecified or vague codes. Precision in ICD-10 CM coding is the cornerstone of accurate risk adjustment and value-based care. Every diagnosis code influences patient acuity, reimbursement, and compliance integrity. Missing chronic conditions can lead to underpayment and misrepresentation of a patient's health status, while unsupported codes increase audit risk and potential financial penalties. Skilled coders transform provider documentation into accurate, substantiated codes that meet the MEET criteria, ensuring each patient's health story is fully captured. The accuracy drives fair reimbursement, strengthens organizational trust among providers, auditors, and payers, and it supports population health management. Ultimately, certified coders safeguard compliance. They uphold ethical standards and they enable sustainable financial stewardship, making them indispensable to both clinical and operational success. One key consideration is how codes are presented in the EHR. Sometimes specific codes are grouped under a generic or unspecified option, and providers may default to that less specific code. This can lead to underreporting severity. Make sure the codes you need aren't hidden under an unspecified grouping and that the chronic options are available and not just acute codes. If providers notice a diagnosis code is missing or unavailable, encourage them to communicate that with their EHR team so that it can be corrected. Another best practice is to add onset and resolution dates to the problem list. This helps anyone reviewing the record understand whether a condition is active or historical. Also, review discharge summaries and specialist notes for new diagnoses to ensure that they are captured accurately. These steps not only improve coding precision, but also strengthen risk adjustment and the integrity of the patient's story. Now let's look at some common coding pitfalls. This slide covers some common coding pitfalls and their impact on risk adjustment. Errors like using unspecified codes, coding history is active, and failing to link manifestations can distort a patient's risk profile. Other issues include the copy-paste documentation, omitting the MEET elements, and ignoring ICD-10 updates. Missing chronic condition validation and inaccurate coding, whether undercoding, downcoding, or miscoding, leads to lost HCCs, lower risk scores, and reduced reimbursement. These mistakes can also increase compliance exposure and audit risk. Upcoding, on the other hand, is considered fraud, and it can result in legal penalties and loss of trust. Accurate coding is essential for proper risk adjustment, compliance, and resource allocation. In the next slides, we'll look at some real-world examples and discuss their financial and compliance impact. Let's check out a few examples of some of these pitfalls. So when we talk about undercoding, it's more than just a missed diagnosis code. It's a missed opportunity to accurately represent the patient's true health complexity. Undercoding occurs when chronic or active conditions that are monitored, treated, and managed are not fully documented or coded. This creates an incomplete clinical picture, which impacts risk adjustment, reimbursement, care management, and quality reporting downstream. From a risk adjustment perspective, Every condition tells a story that drives resource allocation, care coordination, and quality metrics. If documentation is incomplete, the patient appears healthier than what they really are, leading to reduced reimbursement and undervaluing the care provided. It can also affect RAF scores and raise compliance concerns for inaccurate reporting. If a condition is monitored, treated, or managed, it must be captured every year, even stable conditions, because chronic diseases don't disappear. They continue to influence risk, costs, and care planning. Let's look at this example. A 68-year-old patient has type 2 diabetes and CKD stage 3B, with documentation stating diabetes mellitus type 2 with CKD stage 3B, and notes that hypertension and hyperlipidemia are managed. However, the coder assigned E11.9 for type 2 diabetes without complications, removing the linkage between diabetes and CKD. This omission meant that the patient's chart didn't reflect the true disease burden. An HCC 18 in the V24 model or HCC 37 in the V28 model for diabetic chronic complications wasn't captured. The correct coding should have been E11.22 type 2 diabetes with diabetic CKD, N18.32 CKD stage 3B, I12.9 hypertensive CKD with stage 1 to 4 CKD or unspecified CKD, and E78.5 for lipidemia unspecified. This correction makes a significant difference in the risk adjustment accuracy. Linking diabetes to CKD ensures that the correct HCC category is captured and it reflects the provider's management efforts in the patient's health profile. Always link related conditions when documentation supports it. Query when it's unclear and never assume diabetes with unless documented or unless it is linked with the word with in the alphabetical index. But when it is, that linkage is essential for accurate HCC capture and compliance integrity. This slide highlights one of the most common yet overlooked documentation pitfalls, the EHR copy forward error. Copying past medical histories or previous visit notes forward without confirming accuracy can lead to serious coding and compliance issues. In this example, the provider initially documented a complete picture, a patient with COPD and acute respiratory failure. The correct codes should have been J44.1 for COPD with exacerbation and J96.00 for acute respiratory failure. But in subsequent visits, the provider used the copy forward feature without updating the note. The acute condition was carried forward repeatedly, even though it was no longer clinically acute. The coder ultimately assigned J44.9 for COPD unspecified, which underrepresented the patient's severity, lowered the RAF score, and impacted quality metrics. If the pattern becomes systemic, it can raise compliance red flags. EHR efficiency tools are helpful, but verification is critical. Acute conditions should be reassessed at each visit. If they have resolved, you remove them. If they've transitioned to chronic, update the documentation and coding accordingly. Never copy blindly. Even one missed or outdated diagnosis can distort the patient's risk profile and affect reimbursement and care planning. Downcoding happens when a coder or provider selects a less severe diagnosis than what the documentation supports, often unintentionally or out of caution. While it may seem harmless, conservative coding can backfire. Financially, it lowers reimbursement and undervalues provider effort. Clinically, it underrepresents patient complexity, which skews risk scores and resource allocation. From a compliance standpoint, repeated downcoding creates audit exposure and signals inconsistency. Common causes include incomplete documentation, vague condition descriptions, and over-reliance on EHR defaults that assign generic codes. For example, a 72-year-old patient with documented CHF, NYHA class 3, diabetes with neuropathy, and CKD stage 4 was coded with unspecified codes I50.9, E11.9, and N18.9. The correct codes I50.43, E11.40, E11.22, and N18.4 would have captured the true severity and appropriate HCCs. Guidelines state that diabetes with neuropathy and diabetes with CKD are linked conditions unless otherwise clearly stated that they are unrelated. It also tells us to use as many codes as needed to describe all of the complications and conditions a patient has as it relates to diabetes. Accuracy is not upcoding, it's representation. Every diagnosis that is monitored, treated, or managed should be coded to the highest specificity, supported by documentation to ensure compliance, fair reimbursement, and better care coordination. Now that we've seen how errors like undercoding, downcoding, and EHR copy forward can distort risk, let's look at how strong documentation practices prevent those errors. Let's focus on the foundation that supports everything: accurate documentation. Coding can only be as strong as the documentation behind it. Complete documentation captures the full clinical picture and not just the diagnosis, but the story, how it's being managed, evaluated, assessed, and treated. And that's where the MEAT framework comes in. Every chronic or active condition should show evidence that it was addressed during the encounter, whether through labs, medications, monitoring, or treatment decisions. Specificity is also critical. Avoid unspecified codes when the documentation supports a more precise option, because in risk adjustment, specificity can mean the difference between capturing or missing an HCC. Colla- Collaboration is key. Coders should feel empowered to query providers when documentation is unclear. This isn't an audit risk, it's a compliance safeguard. When coders, providers, and auditors work together, we ensure that patients' full complexity is accurately represented. Accurate documentation drives the accurate coding, and accurate coding drives fair reimbursement, better quality metrics, and the compliance protection. This scenario shows why proactive querying is essential. A patient comes in for an annual wellness visit with a history of type 2 diabetes, controlled blood pressure, and A1C of 8.2. The provider notes occasional neuropathy symptoms but doesn't explicitly link them to diabetes or confirm the diagnosis. The coder assigns E11.9, diabetes without complications. While coding E11.42 for diabetic polyneuropathy might seem logical, doing so without clear documentation would be non-compliant and create audit risk. The correct approach is to compliantly query the provider. The patient's documentation indicates polyneuropathy symptoms and type 2 diabetes. To ensure accurate coding that reflects the patient's conditions, could you please clarify the diagnosis and the relationship? Offer options such as E11.42 for diabetes type 2 with polyneuropathy, polyneuropathy due to another specified cause, idiopathic polyneuropathy, not clinically significant, or unable to determine for providers to choose from. If confirmed, E11.42 accurately reflects the patient's condition and captures the appropriate HCC, improving risk adjustment and reimbursement. Also, make sure the provider updates their documentation to support the polyneuropathy diagnosis with an addendum signed and dated by the provider. In the case that querying the provider is not an option, unfortunately, you would have to use the code for diabetes without complications. The takeaway is that querying isn't a burden, it's a safeguard. Every query helps close gaps between documentation and coding, ensuring compliance, accurate risk scores, and proper representation of patient complexity. In this scenario, the provider documented chronic kidney disease, stage 3, and hypertension, with no mention of diabetes. The coder correctly assigned I12.9 and N18.30 based on what was documented. However, what is missing is just as important as what's present. CKD and hypertension frequently coexist with diabetes, and failing to explore that connection can lead to a hierarchical coding gap. If the patient actually has type 2 diabetes and it is reflected in previous encounters, it's the underlying cause of CKD. The correct code would be E11.22, which places the patient in a higher HCC category and more accurately reflects disease severity. Without documentation of the diabetes, the coder couldn't capture this link, resulting in a lower risk score, potential underpayment, and misrepresentation of the patient's condition. This also introduces compliant risk if ambiguity isn't addressed. The solutions is to query the provider whenever documentation is unclear using simple non-leading queries. Like documentation in previous health records supports further specification of a condition. Diabetes with CKD stage 3 was documented on a progress note dated 12/30/24 and supports further specification of a condition. You would copy and paste the documentation of type 2 diabetes with CKD stage 3 and ask the provider to clarify the etiology of the CKD and use multiple choice answers like CKD stage 3 due to type 2 diabetes, CKD stage 3 due to other condition, which they would need to specify, and clinically undetermined can close the gap and ensure accurate coding. Ultimately, accurate documentation drives accurate risk capture, and every query sent strengthens both data integrity and financial accuracy. In this scenario, the provider documented congestive heart failure and noted the patient is on Lasix and a beta blocker. The coder assigned I50.9, which is technically correct, but it lacks specificity. There's no mention of whether the heart failure is systolic, diastolic, or combined, nor any indication of chronicity such as acute, on chronic, or compensated. This matters because heart failure type directly influences both clinical management and risk adjustment scoring. For example, I50.22 for chronic systolic heart failure maps to a higher HCC category than I50.9. Using unspecified codes dilutes accuracy, lowers the HCC weight, and results in underpayment. It also creates documentation gaps that affect reporting and patient stratification and can trigger audit risk during RADV reviews. The solution is to query the provider for clarification. Can you specify the type and chronicity of the patient's heart failure? And list multiple choice answers, including documentation of congestive heart failure and I50.22. Additionally, educate the providers to document the full picture, type, severity, and current status. Make sure the provider updates their documentation to include that specificity. Specificity is power, and when in doubt, query it out, especially for high weight chronic conditions like CHF, CKD, and diabetes complications. Accurate documentation ensures accurate risk capture, compliance, and fair reimbursement. Now, I will turn it over to Dominique to talk in more detail about the conditions that are often miscoded. Hello, Dominique.
Hello, Missy, and thank you. Good afternoon, everyone. Next, we'll review some of the most frequently miscoded risk adjustable conditions and walk through a few scenarios from a risk adjustment perspective. We will focus on chronic conditions that are often miscoded and how vague or incomplete documentation can distort the clinical picture. High impact conditions such as diabetes, chronic kidney disease, heart failure, COPD, and asthma, behavioral health disorders, pulmonary embolism and DVT, cancer staging and metastases, arrhythmias, vascular disease, obesity, and history codes are common sources of error. These gaps lead to underreported patient complexity and lower RAF scores, affecting reimbursement, care management, and quality outcomes. Frequent issues include missing complications, incorrect staging, generic codes, confusion between acute and chronic status, and incomplete details like BMI or laterality. In the next slides, we'll break down a few of these conditions, explain why errors occur, review real-world scenarios, and show how they impact risk adjustment, true patient complexity, and organizational performance. Diabetes affects over 38 million Americans and nearly 1 in 4 Medicare beneficiaries. It's a lifelong condition that directly impacts risk adjustment factor scores and care planning. Many complications like neuropathy, chronic kidney disease go undocumented, which lowers risk capture. When these complications are coded correctly, they trigger higher HCC values. For example, E11.42 for diabetes with neuropathy maps to a higher risk category than E11.9 alone. Annual recapture is essential. If the patient is treated or monitored this year, it must be coded again to remain risk relevant. This slide highlights how documentation drives accurate risk capture for diabetes. A common pitfall is defaulting to the unspecified code E11.9, which eliminates HCC capture for chronic complications and significantly lowers risk scores, even when the patient has active issues like neuropathy or retinopathy. To avoid this, documentation must clearly link diabetes with its complications, such as type 2 diabetes with neuropathy or with CKD stage 3. These linkages are critical for coding accuracy and HCC validation. If the relationship is unclear, query the provider rather than using a generic code. An example is if documentation states patient with type 2 diabetes reporting tingling and numbness in both feet, and the provider confirms diabetic neuropathy. The correct code is E11.42, type 2 diabetes with diabetic polyneuropathy. Coding E11.9 would lose the complication, resulting in lower reimbursement and an inaccurate disease profile. So some best practice tips. Always link diabetes with specific complications. Query the provider if linkage is unclear. Avoid unspecified E11.9 unless truly applicable. Reassess and recapture diabetes annually for active management, even if stable. Accurate documentation is more than compliance. It reflects the true clinical picture, supports quality care, and ensures patient complexity is fully recognized in the risk model. Chronic kidney disease, or CKD, is frequently underdocumented or coded without the correct stage, which directly affects reimbursement, quality scores, and risk adjustment. Because CKD is a progressive condition, capturing the most specific documented stage from N18.1 through N18.6 is essential, and codes should be updated as the disease advances. End-stage renal disease, or ESRD, which is N18.6, carries significantly higher clinical and risk adjustment impact, so it must be used only when the patient truly meets ESRD criteria. When present, dialysis dependence should also be captured with Z99.2. Avoid defaulting to unspecified CKD codes like N18.9 unless absolutely necessary, as this may misrepresent severity. When diabetes contributes to CKD, ensure documentation clearly links the conditions using phrases such as due to or with, supporting combination codes like E11.22 or E10.22. Finally, always clarify unclear or conflicting documentation, whether related to staging, dialysis status, or progression from CKD stage 5 to ESRD. So the coded record accurately reflects the patient's current clinical picture. CKD is a progressive condition that requires precise documentation for both clinical and financial accuracy. When documentation is insufficient, it leads to missed opportunities for risk capture and revenue accuracy, which can significantly impact organizational performance. Incorrect or unspecified staging understates the true disease burden, making patients appear less complex than they are. This is not this not only affects funding for high need populations, but also influences quality measures such as HEDIS and STARS. Additionally, failing to link end-stage renal disease properly results in underreporting complexity. From a risk adjustment perspective, CKD stages 3 to 5 and ESRD map to HCC 138, which carry substantial financial weight, while stages 1 through 2 do not risk adjust. They must still be documented for quality tracking and care planning, especially for progression of the disease. Without this, funding for high need populations is compromised and quality scores suffer. Heart failure is a high impact chronic condition and one of the most frequently miscoded diagnoses in risk adjustment, making accurate and specific documentation essential. Each type, which is systolic, diastolic, or combined, carries a different risk weight in CMS HCC model. And providers must also capture laterality, right, left, or both ventricles, chronicity, chronic, acute, or acute on chronic, and whether the patient is currently decompensated. Missing these elements leads to underreported complexity and lower RAF scores, as unspecified heart failure defaults to I50.9, which does not reflect severity or type. Thorough documentation supports proper risk stratification, compliance, and care coordination, ensuring clinicians accurately reflect patient status and coders can capture the appropriate HCC. Encourage complete documentation and query when details are unclear. COPD and asthma are common chronic respiratory conditions that often appear on audit lists because providers may document them without the level of specificity needed for accurate risk adjustment. While both conditions map to CMS HCC codes, RAF impact varies based on the detail. For COPD, documenting in acute exacerbation or lower respiratory infection significantly increases risk weight compared to stable disease, and providers must clearly note sudden worsening, infections, or decompensation to support codes such as J44.0, J44.1, or J44.81. Otherwise, documentation defaults to nonspecific codes like J44.9, which underrepresents patient's health profile. Asthma requires documentation of severity, mild, moderate, or severe, and whether the patient is experiencing an exacerbation or status asthmaticus. Using nonspecific codes like J45.909 or J44.9 for unspecified asthma or COPD results in lost risk capture, inaccurate RAF scores, and incomplete clinical representation. To support accurate coding, providers should document severity, exacerbation status, infection details, and complications, and coders should select the most specific ICD-10 codes supported by the provider's documentation. Query when details are unclear, especially for overlapping conditions like asthma and COPD. Cancer coding, likewise, is one of the most complex areas in risk adjustment and a frequent source of missed opportunities because complete documentation is often lacking. To accurately reflect patient complexity under CMS HCC V28, providers must clearly document cancer type, stage, metastatic status, and whether the cancer is active or historical. Active cancer should only be coded when the patient is receiving treatment such as chemotherapy, radiation, immunotherapy, or palliative care, or is under active surveillance. History codes such as the Z85 series apply only when the cancer is no longer active and no treatment or surveillance is occurring. Using history codes during active treatment is a compliance risk. When metastases are present, coders must assign both the primary cancer site and each metastatic site. Since omitting metastatic involvement or using unspecified codes significantly reduces RAF capture and misrepresents true disease burden. Accurate documentation continues to ensure ensuring proper staging, reflects severity, and support correct risk stratification, reimbursement, and audit protection. Ultimately, cancer documentation must tell the full clinical story by specifying the cancer type, stage, metastatic involvement, and treatment status. Cancer coding, as you can see, continues to be one of the most error-prone areas in risk adjustment, not because the rules are overly complex, but because small documentation gaps create major downstream impacts on RAF scores, compliance, and the accuracy of the patient's clinical story. One of the most common errors we see is coding cancer as history while the patient is still receiving active treatment or is under active surveillance. When this happens, the active HCC drops off entirely, which not only lowers the risk score, but also creates a conflicting medical narrative that follows the patient from visit to visit. These documentation conflicts raise compliance concerns and can prompt auditors to question the integrity of the medical record. Another significant and often overlooked issue is incomplete capture of the metastatic or secondary disease sites. When a provider documents that cancer is spread, whether to liver, lungs, bone, or another organ, that metastatic site must be coded in addition to the primary malignancy. Missing metastatic involvement is one of the highest value missed opportunities in risk adjustment because the metastases significantly elevates clinical severity and RAF weighting. For example, a patient undergoing chemotherapy for colon cancer with documented liver metastases should be coded with both the primary malignancy code, C18.9, and the metastatic site code, C78.7, supported by the chemotherapy encounter code, Z51.11. If we instead use only the primary cancer code, or worse, a historical code, we severely understate the patient's disease burden and misrepresent the intensity of services the patient requires. Accurate cancer documentation should always capture stage, metastatic involvement, and whether the cancer is active versus in remission. These elements are essential not only for the correct HCC mapping, but also for aligning the coded record with the patient's true clinical needs. When coding reflects clinical reality, organizations can better support care coordination, predict resource allocation, and maintain compliance. Ensuring these metastatic sites, treatment status, and disease progression are fully documented and coded helps protect revenue integrity and ensures high-need patients receive the level of support they require. Vascular and thromboembolic conditions such as deep vein thrombosis, pulmonary embolism, and peripheral artery or peripheral vascular disease are frequently miscoded because documentation often omits key details about acuity, anatomical site, and current treatment. Accurate risk adjustment depends on clearly distinguishing whether a condition is acute, chronic, or historical, and whether the patient is still receiving anticoagulation or has an unresolved clot. For example, DVT is commonly misclassified as history even when the patient remains on anticoagulation. In these cases, the condition should be coded as active with specificity around acute versus chronic presentation and the exact vessel involved. PE is similarly miscoded. History codes should be used only after full resolution. with no active treatment or surveillance otherwise. An active PE code is required, noting whether core pulmonale is present. PAD or PVD also leads to missed specificity because providers often document only the acronym, even though peripheral artery disease no longer risk adjusts under V28. Associated complications such as ulceration, rest pain, and claudication must still be captured to accurately reflect severity and guide care planning. Clear documentation of acuity, anatomical location, where the event was provoked, treatment status, and complicating features ensures coders can assign the most accurate ICD-10 codes supporting compliance, clinical validity, and appropriate resource planning for high-need populations. Now let's look at some scenarios of frequently miscoded conditions. The 79-year-old male patient has a documented diagnosis of hypertension and diabetes in the provider notes. Provider also documents that the patient has a history of diabetes, hypertension, and chronic kidney disease, and is on dialysis 3 times a week. But the documentation does not specify staging of CKD or ESRD. The coder assigns E11.9 type 2 diabetes mellitus without complication and I10 essential hypertension. What was missed? Please put your answers in the chat. If you said the coder failed to capture E11.22 type 2 DM with diabetic chronic kidney disease, N18.6 ESRD, and Z99.2 dependence on renal dialysis, you are correct. This scenario highlights several important points to keep in mind when documenting and coding CKD and ESRD. When diabetes contributes to kidney disease, be sure the linkage is clearly documented so the correct combination codes, such as E11.22 with the appropriate N18 series staging, can be assigned. If the patient is receiving dialysis, both ESRD N18.6 and dialysis dependence Z99.2 must be captured to reflect true severity. It's also essential to stay aware of V24 versus V28 updates, since CKD and ESRD were reprioritized within the renal hierarchy and now impact risk differently. If documentation doesn't specify whether CKD stage 5 has progressed to ESRD, query the provider to clarify disease status. And throughout every chart, make sure chronic conditions are clearly addressed, assessed, and treated. Meet documentation ensures accurate capture and supports the clinical story. Here's a scenario of heart failure. A 57-year-old female diagnosed with chronic combined systolic and diastolic heart failure. Patient is stable on medication and has had no acute decompensation. Past medical history is acute on chronic diastolic heart failure. In this scenario, the coder coded I50.9. What should the coder have coded? A, I50.9, heart failure, unspecified, is the correct answer. B, I50.42, chronic combined systolic and diastolic heart failure. Or C, query the provider as there needs to be more specificity. Please put your answer in the chat. Okay, I see some answers coming in. Okay, if you answered B, you are correct. It might seem like a no-brainer, but this is a common error that is seen on audits. This is a simple but costly example. The provider clearly documented chronic combined systolic and diastolic heart failure, which points to the ICD-10 code I50.42. But the coder selected I50.9, heart failure unspecified, either due to EHR autocoding or lack of review of the documentation. Under the old CMS V24 model, Both codes map to the same HCC, so there wasn't much visible impact. Under V28, however, unspecified heart failure no longer maps to any HCC. That one vague word, unspecified, wipes out the entire risk capture of this chronic condition. Documentation must describe the type, systolic, diastolic, or combined, and status, acute, chronic, or acute on chronic. Providers can use phrases like chronic systolic heart failure, stable on medication, or acute on chronic diastolic heart failure. Coders must verify that the ICD-10 reflects exactly what's written, nothing more, nothing less. This is a prime example of downcoding through documentation. It looks minor, but has major financial and clinical ripple effects. This scenario is one of the most frequent findings for respiratory conditions. A 72-year-old male presents with increased cough, shortness of breath, and sputum. History for COPD. The provider documented an acute exacerbation, increased cough, sputum, and shortness of breath, and even prescribed prednisone. The coder codes J44.9, COPD unspecified. What should the correct code be, and what is this an example of? Please put your answer in the chat. Okay. That documentation supports J44.1, COPD with acute exacerbation, and if you said downcoding or undercoding, you are correct. Many coders or EHR defaults assign J44.9, COPD unspecified, thinking it's safer. So when you undercode or downcode COPD, you're not just losing reimbursement, you're also misrepresenting clinical severity. Teach providers to include clear language like stable COPD, no exacerbation, or COPD with acute exacerbation treated with a steroid taper. A 54-year-old male patient presents for a follow-up visit. The provider documents that the patient continues on Eliquis for chronic DVT in his left femoral vein. No new swelling or pain. Stable on anticoagulation. The coder assigns Z86.718, personal history of other venous thrombosis and embolism, assuming the DVT is resolved because the patient is stable. Is this correct? Please put your answer in the chat. The correct coding is I82.5 series for chronic embolism and thrombosis of the left femoral vein. Example, I82.512 for left femoral vein. At Z79.01, long-term use of anticoagulants to reflect ongoing therapy. This is in fact incorrect because the patient is still on anticoagulation for an unresolved clot, which means the condition is active, not historical. Using your history code underreports disease burden and lowers the risk adjustment factor. So as we close today's session, remember that coding accuracy is more than numbers. It's about telling the patient's story completely. Every ICD-10 code reflects disease burden, drives risk scores, and ensures resources for care. When chronic conditions are missed or miscoded, that story becomes incomplete. HCC coding depends on documentation. Diagnoses must be supported with MEET criteria, monitored, evaluated, assessed, and treated, or show clear evidence of treatment or follow-up. Accurate capture strengthens care coordination, reduces audit risk, and improves data integrity for reimbursement, quality reporting, and population health. Accuracy equals reimbursement. Unsupported codes lower risk scores and funding, while increasing compliance exposure and audit risk. Strong documentation protects against recoupments and builds a solid audit trail. It also impacts quality metrics, star ratings, and performance incentives. Finally, thorough documentation reflects clinical excellence and professionalism, building trust and collaboration. Remember, strong documentation protects patients, compliance, and your bottom line all at once. Now I'll pass it over to Jacqueline.
Thank you, Dominique. Thank you all for joining our educational webinar today. We appreciate your time and hope you found the session informative. We offer group risk training for your practice tailored to your needs, whether you prefer virtual sessions or on site training. Please use the QR code provided to give your feedback on today's presentation. Additionally, if you're interested in group training, scan the QR code to show your interest. I would like to give a big thank you to our speakers, Misty Leggett and Dominique Brown, for their insightful contributions today. And again, I am your host, Jacqueline Duncan. We look forward to seeing you at our next risk adjustment webinar in January 2026. We hope you enjoy and have a wonderful holiday.